Thank you, Team Genomics. The last talk that we've reserved the best for the last, the dynamic Dr. Brown, who's going to give us an update on Open UK.
Best till last day. Okay. I just want to say a huge thank you to everybody that's been involved in organising the meeting today. So the college have just done an absolutely brilliant job of organising today, and I gather we had 900 people registered to attend online, which we may not have told the speakers before now, because obviously it's quite the daunting thing. Incredibly grateful to the speakers. What we try to do every year is to bring together everything that we have been working on and try and present it to you so that it can fuel your quality improvement processes over the course of the next year, but also to try and fertilize discussion about what our objectives, what we're going to try and be working on over the next few months and years will be. So as you've just seen, we've had a lovely talk about genomics there. Lots of food for thought, lots of things that we need to put in place. And Jaffa and I would recognise that genomics is kind of new to the Quality Improvement Party nationally. So we need to take this further and embed some of those principles in the national quality improvement work that we're doing. And I'd like to say thank you to Suresh, who's been a brilliant chair today. So absolutely fantastic job. You've been self-congratulatory on the timekeeping, but we think you've done a fantastic job in all other regards as well. Okay, so I've put a picture up here from earlier on in the day with the need for control, for confidence, for empowerment and independence from our patients, which gives you just a slight clue that I may have written my slides at lunchtime. So how do we translate this into better care for our patients? What are the rules of the game? If we go back to 2015, we had a meeting of all of the regional epilepsy networks, and we presented to the national clinical director at the time, and we made a powerful argument for routine access to co-located mental health care. And we were very excited that the national clinical director heard our argument loud and clear and could completely see that in every regard it was a faultless argument supported by data and evidence. And we said, right, what's the next step then? And she said, I have no idea. Because actually nobody knows what the rules of the game are here. How do we actually translate all of the wonderful research that's been done and all of the national processes and guidance into better care for our patients? Nobody really knows the rules of the game, but I'm going to try to summarize what next steps will be for everyone so that we can all get better care for our patients. So who are we playing the game with? There's actually no good reason why there's a picture of me being attacked by my dog here. I just thought it would be an important thing, and Colin challenged me earlier on to get a picture of my dog in, so that's why the picture of the dog is there. So who are we playing the game with? When you play a game with someone, it can mean one of two things, can't it? You play a game against someone, and or you can play a game with a team. And I think that has particular meaning in epilepsy politics, because NHS England have been the door that we've been banging on for the last sort of eight years. So it's felt a little bit like we've been playing the game against NHS England. But now, as you've seen from Jaffa's presentation, we're actually playing the game with NHS England. So transformation is a game that we must play with our colleagues in NHS England. And of course, what that translates to is the ICBs, the integrated care systems, the integrated care boards. So this is the game of epilepsy quality improvement is now a game that we play with the ICBs. So I'm gonna produce one clear message here, and I'm gonna do it in the style of the Spanish Inquisition. So you may remember that the Spanish Inquisition said that nobody expects the Spanish Inquisition. Our chief weapon is surprise. So that's it's one clear message. But then they went on to say, our two chief weapons are fear and surprise. because they couldn't resist adding in another message. And then they said, our 3 weapons are fear, surprise, and ruthless efficiency. And then they said that amongst our weaponry are such diverse elements as fear, surprise, ruthless efficiency, and an almost fanatical devotion to the Pope. So you start off with one key message and you end up sort of sandwiching at least 4 in. So one key message, and then I'm going to add in some more. So I'm speaking here to individual clinicians, individual epilepsy units, individual trusts. And what I'm saying is that the one key message is that you need to meet with your ICB. You need to meet with the CYP lead for chronic conditions, just the children and young persons lead at your ICB, who may be quite hard to identify. They may not actually have one, but there will be someone at the ICB that takes responsibility for pediatric epilepsy care. And you need to meet with them soon. And that is the one key message here, because we'll talk about the levers that you've got at your disposal, but every single clinical NHS unit needs to meet with their ICB, because a lot of the quality improvement processes will follow through from that. Now, what levers have you got? I found this slide, which obviously has He-Man saying that he has the power, he has the levers, and in the middle it says, I have the power blank meme template. So the template here is one that you're going to fill in, particularly since the individual things that you're going to find to work on in terms of quality improvement are going to vary according to the particular environment in which you work. So it's not going to be the same for everyone. There's been a clue throughout this entire day. We've got epilepsy. It does look like it looks like I've circled Suresh's head, but actually just behind you it's got the word Epilepsy12, you see. So Epilepsy12, Epilepsy12, Epilepsy12. Epilepsy12 has always been important to our quality improvement processes, but it's absolutely crucial now. So I'm saying that you're going to want to make an argument to the ICB that they should help you to change your services for the better. The data that they will use to drive this is Epilepsy12 data. And once you've made a change, you're going to measure that improvement with Epilepsy12 data. The more you enter data, the better quality data you're going to be able to see. And we've heard today that there are really exciting sort of real-time demonstrations of epilepsy quality that will be available through the Epilepsy12 platform, landing on your doorstep in December, if I'm right. So this is a plea to please use Epilepsy12 data, review your own unit's data, show it to the ICB, but in particular, please enter data. Make sure that you enter data in great detail. We talked about the rules of the game. So we're talking about a very specific game here, but in general, when you want to, the rules of the game, when you want to improve quality, then you need training really in how to do quality improvement. And fortunately, this is laid on for you here with the equip process. So you will have heard from Mel earlier that October the 9th is the deadline for applications for the next iteration, the next run of the equip program. So please consider whether you need any help and support with your quality improvement skills in order to drive change in your unit. So please register for equip. The bundle. Jaffa, 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 Jaffa. So this is genuinely one of the most exciting things that's happened in pediatric epilepsy quality improvement for decades. So NHS England has taken the standards from NICE guidance and translated them into deliverables and made them a priority for the integrated care boards. So the ICBs are going to receive the bundle within about 2 weeks, and it's going to mean that the ICBs are going to be passionate about changing aspects of transition, mental health care. the Children's Epilepsy Surgery Services and and complex epilepsy care, and of course variation in care. There are going to be realistic, sort of, time-sensitive changes that all ICBs should be looking to make, and so your ICB is going to have this bundle in about 2 weeks. So that appointment that I suggested, that meeting that I suggested you set up with the ICB, just put a reminder on your phone now to contact the ICB in about 2 weeks' time when the bundle has landed, because this is going to be an incredibly powerful lever for change. The ICBs are going to be on your side in terms of pulling together change for the benefit of your patients. So I chaired the Variation in Care group, big shout out to everybody that participated in Variation in Care. Probably the single most important standard within Variation in Care is about access to epilepsy nursing. So if there are patients within your patch who don't have access to an epilepsy nurse, this is going to be a landmark time. I think we should be in a situation after this bundle lands where there is no patient in the whole of England that does not have access to epilepsy nursing care. So my double S seems to have slipped over onto the next line. So cost effectiveness data. Isabel Heyman was sharing with us earlier on that she felt the cost effectiveness data from the mice study wasn't earth shattering. But I disagree. I think what that they've done with the mice study is incredibly earth-shattering. They've proven that routine screening and intervention for mental health care for children with epilepsy is cost neutral. That it doesn't. You spend £1,400 on a package of care for a child, but you get that money back again because of reduced acute hospital admissions and all of the other reduced appointments. So to demonstrate that we can deliver exactly what NICE guidance has been saying we should deliver since 2004, and that we can do so in a cost-neutral way, is incredibly powerful. So please discuss this cost effectiveness data with your ICBs. There are many other aspects of epilepsy care for which there is excellent cost effectiveness data, and Jaffa's referred to ways in which we're looking into that at NHS England level. Another lever, so Core 20 plus 5. The asthma lot, they're all very excited about deprivation because things like smoking and obesity and socioeconomic deprivation are highly relevant in the care of asthma patients. But Core 20 plus 5 clearly talks about the importance of equity of access to care for children with learning disability and autistic spectrum disorders. So it's incredibly important that you use those levers. So Core 20 plus 5 is another reason why your ICB will be incredibly motivated to help you support your patients who have epilepsy plus other things. And as we've heard from Colin and many others today, most of our patients have epilepsy plus other problems. So it's incredibly important that we use these levers to achieve better care for our patients. So it is imperative that we all play this game. We must all arrange to meet our ICB to discuss the gap between what we should be doing for our patients and what we are doing. We need to be able to map that gap using Epilepsy12 data. We need to think about some things that we're going to try to change, and you need to ask yourselves whether some training in quality improvement processes would be helpful. So eQuip is on offer. Use your powers of persuasion with all of these levers, and measure the improvement that you create with your top-notch Epilepsy12 data. And once you've achieved that, then just move on to the next thing, because there's always an infinite amount of things that we can do to improve the situation. So I can't tell you that there is a magic button that you press and then a ton of funding comes flowing your way to improve your care. But if you follow this kind of process and use these levers, then the ICBs will be highly motivated to help you. Thank you.
Two questions for Dr. Brown. Anything online?
We've got one online, which I think is sort of a general comment for anyone who can answer or wants to answer. Does anyone have some perspective on how many patients there should be per pediatrician with interest in epilepsies?
Okay, yeah. So it's a nice thorny question, and it's causing Jaffa's toes to curl up. So the question was, do we have any data around the number of patients that a paediatrician with expertise in epilepsy should be dealing with? So we have a standard that was generated, I think it'd be fair to say, fairly sort of, off the cuff by the Royal College of Nursing, so that epilepsy specialist nurses should look after a cohort of about 250 epilepsy patients. We don't have the same sort of data around paediatricians with expertise in epilepsy, but Dr. Parker is raising his hand, so always happy to have a reckon.
It's a nuanced question, and I think it's very difficult to have one size fits all. It is something we could work towards having, if you've got a population of 500 children on anti-epileptic drug treatment, blah, 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 blah. There are a lot of confounders there, because you may see a lot of children in those clinics who don't have an epilepsy or could have an epilepsy. So how do you quantify that heavy workload? And the other group is the children with complex disabilities and epilepsy. It can be very labor intensive, but maybe they're picked up in a specialist school and seen by a developmental pediatrician who doesn't directly specialize in epilepsy. But it seems to me the answer is how many paediatricians in each district? You certainly need more than one. And for what I've seen it working badly, it's with one person doing it all, which Richard did in Peterborough for a long while. And when he left, he did it.
There's some potential for misunderstanding.
Yeah, he did it. He did very well in Peterborough. When he left, nobody could do it on their own. As we know, Richard's irreplaceable. So I think, and where I've seen it work well is if there's somebody from the community side actively involved in epilepsy, it greatly improves quality, just because you get the sorting hats splitting out some children from specialist schools. But I think a team. And for nursing cover, of course, one person's away for 6 weeks a year on annual or study leave. And for the parents, they want that phone answered at 9 a.m. on a Monday, not 9 a.m. the following week. So we're talking about daily cover from nursing specialists and enough nurses to achieve that. And I think we're talking about daily cover from a pediatric perspective at both secondary and tertiary. So you need more than one person doing that. So it may be one needs to do a bit. That's something would be well covered nationally, Richard, to have a think about some core, because we're often meeting that question why services are in trouble, and often it's those issues aren't addressed.
Fantastic. So time for one
mutual admiration.
Yes, yeah. Thank you very much. Thank you.
All right. So Dr. Brown has covered everything I wanted to say in my concluding remarks. Basically, he summarized the whole day, so there is nothing much for me to say. The one thing I want to kind of repeat actually is, for many years we've been frustrated with the problems that we have had in kind of managing children with epilepsy. And what I've seen in the past year is that I think a lot seems to, there is a momentum building. I think overall it's really exciting to see NHS England kind of supporting a lot of these projects and all of us coming together. So I think in the coming years it's going to be exciting times. So positive, optimistic for the future. And finally, I want to thank the team for inviting me to chair this meeting. It's been fantastic. I've really enjoyed it. Thanks to everyone from Open UK, Epilepsy12, Amani and Nikki. You've done amazing organizing work. And thanks to everyone who's kind of supported this meeting. So have a safe journey home, and then we'll meet next time.
Epilepsy12 aims to help epilepsy services and those who commission health services to measure and improve the quality of care for children and young people with seizures and epilepsies in England and Wales. The National Clinical Audit is commissioned by the Healthcare Quality Improvement Partnership and funded by NHS England and the Welsh Government. The current Round 4 contract has been delivered by the Royal College of Paediatrics and Child Health from the 1st of April 2022. Epilepsy12 looks at the care children and young people with epilepsy receive in the first 12 months following their first assessment. Paediatric epilepsy teams enter patient data onto the audit platform so that the Epilepsy12 team can use this information to publish reports about the quality of care provided to children and young people with epilepsy. The reports show where services are doing well, as well as highlighting areas where there is room for improvement, and makes recommendations for how services can improve their care. They also provide extra resources for healthcare professionals and for patients and their families. The Epilepsy12 audit is supported by the Epilepsy12 Youth Advocates, who are a group of epilepsy-experienced or interested children, young people, and families who volunteer together to improve care for epilepsy patients and their families. The Youth Advocates lead award-winning projects and create resources for patients, families, and healthcare professionals to amplify the voice of children and young people with epilepsy. The National Data Opt-out, or NDO, allows patients in England to opt out of their confidential patient information being used for research and planning. Epilepsy12 is exempt from the National Data Opt-out. This is because not including information about some patients may make the reports misleading. This would make the reports less effective and could risk the safety of patients. Parents and patients can still choose for their information not to be used for the Epilepsy12 audit. To find out more about how we use your child's information to help improve care and your rights, you can visit www.rcpch.ac.uk/epilepsy12. Please contact the team if you have any questions or want to get involved.